Matthias, thank you very much for coming to the event. I'm particularly pleased that you agreed to come because we've had this very good relationship through the journals over the years. So it's a pleasure to welcome you to Madrid. See, one of the things that in the field of diabetes has struck me as very interesting scientifically, but problematic from the therapeutic point of view, is that now we have just too many targets, yeah? And we have these targets in different organs. There's the immune system, there's the fat, the liver, the muscle, and certainly your own contributions to the brain are pretty interesting. Where do we go with all of this therapeutically? How do we go about parsing this out and finding the new therapeutics that we need for diabetes?
Well, Carlos, you're absolutely right that this is an important challenge and something we're all struggling with. We can't complain that we don't have enough targets because every day virtually there's another paper, not all of them in your journal, but some of them, that shows that another important pathway has emerged, has been discovered. How can we target all of them? It won't be possible. So we need strategies how to prioritize, how to separate one from the other, which ones are the essential key ones and which ones aren't. The strategy that we have taken, for example, is find orientation with something that actually works. And that example is bariatric surgery. We know that after gastric bypass, Roux-en-Y gastric bypass or gastric sleeve operations, there is sudden improvement in glucose metabolism and there's body weight loss, which actually occurs mostly later. So there's something going on there that works. So we have been trying to focus on signals that could be associated with that, that also have been discovered as targets regulating metabolism otherwise. And then in our second phase, we have pulled several targets together. That's our second strategy. Go with something that works and then target simultaneously several targets at the same time, several pathways at the same time. So we have come up with these combination therapies that we try to put into single molecules and hope that some of them can be translated all the way from cells to mice into clinic.
So combination therapies as in one molecule acting on different receptors?
Right. I actually believe that several molecules would be fine, cocktails or co-injections or something. However, getting that to clinical studies with pharmaceutical partners will be impossible at some point. If you want to combine 4 or 5 different pathway signals, then you have 24 combinations with controls that you need to test, and that won't go into phase 2 and phase 3 studies. Therefore, we try to package them chemically engineered into single molecules together with the chemist Richard DiMarchi and hope that some of these approaches are powerful enough and still safe to do what otherwise only surgery can do.
This is very interesting. You see, because in thinking about the field of metabolism and in comparison to other fields in biomedicine, I think that there's something that one can learn from the field of oncology, where people have been thinking about combination therapies for quite a while, where people have already developed bispecific antibodies that do 2 things at the same time. And it's fascinating to see that in the field of metabolism, we may have to go in that direction. And there are many things that one can discuss about this. One of them could be in terms of if such a molecule makes it into trials and into the clinic, or if you have to give 2 therapies, how are we going to price this? Will it be accessible to people? But let's not go there. Instead, let's talk about the design of these studies with different drugs, and more than the design, the fact one fundamental difference between oncology and metabolism is that in the case of oncology, the treatment is acute. Yeah, you either cure the person or not, but this is not going to be something that the person is going to have to be taken forever. Whereas in metabolism, I think we can think about it as a more chronic condition in which the safety barrier is much higher. So do you see that as an important challenge here, or do you think that these new approaches that derive from bariatric surgery will actually be curative so that we don't have to give them all throughout the life of the patient?
I think a little bit of everything, but I completely agree with you that cancer research in many ways is ahead of us, that we can learn a lot by looking at what they're doing, but there are also challenges that both research fields are facing. So, for example, oncology and cancer research have recognized early and had the opportunity to provide evidence that there can be such a thing such as personalized medicine, individualized therapeutics. There are certain targets that they found that can be targeted with certain drugs in certain subpopulations that make a lot of sense in these, but not other populations. And my colleagues and we are convinced that something similar is going on in, for example, type 2 diabetes. This isn't one disease. There are many subpopulations where specific things went wrong, and maybe, we believe, one subgroup will need a GLP glucagon coagonist, but another one benefits greatly from metformin. And another one may just really need bariatric surgery with everything that brings with it. It just shows you also that our portfolio isn't big enough. There's many other therapeutic options that we need. But what's even more missing is knowing enough about biomarkers, knowing enough about identifying these patient subpopulations in diabetes to be able to make these choices. So a personalized therapy, and then maybe in the very distant future, a personalized prevention is what we're aiming for. But we're far away from that.
That's very interesting, because this concept of personalized healthcare is, of course, very mainstream in the field of cancer. And in the field of metabolism, you can begin to see that people who do large-scale genetic studies are beginning to identify different variants that may represent different subtypes of disease. So I think that you're completely right that there may be further similarities with the field of oncology, which brings additional challenges, such as, will we have enough patients so that it's viable for a company to try to develop these new therapeutics, and where exactly do we focus on that? How do we diagnose it so that we know that this is the right phenotype, which has to do with the biomarkers that you were talking about. So I think that is going to be quite challenging going forward. So in your talk today, are you going to cover some of this ground, or are you going to focus more on the brain? What is the sort of thing that is exciting you more these days?
Well, I understand 15 minutes, so there will be excitement limited to 15 minutes. But I think I'll focus on some of these novel therapeutic approaches, some of these strategies I just shared, some unpublished data on how combinations of not only peptide and gut hormones, but also steroids on top of peptides can be used to direct effects to certain cell populations and not others. I'm quite excited about those and hope that we can move as quickly as possible toward testing those translationally in the clinic. The neuroendocrine and brain research that we keep doing actually synergizes nicely, because it turns out that if you really want to treat and prevent type 2 diabetes, you need to treat and prevent obesity, at least on an epidemic level. And if you really want to do that, the brain needs to be involved. This is where appetite regulation, this is where burning of calories is modulated, and this is where satiety is controlled. So a lot of our neuro research that we have been doing over the years informs our targeting, which afferent factors are we going to combine into the next treatment, and therefore a little bit of that will be in my talk as well.
Well, I look forward to hearing it, and thank you again for joining us at this event.
Thank you very much.